Hey guys, thanks for taking a couple of minutes and going through this with me. I'll go as fast as I possibly can. So there has been a question between Aspire and Echo Lab. So we both have different perspectives. I say we, but they have both different perspectives. Echo Lab has done significant research in saying that these PCRs are effective and that we should follow the protocols for that. I want to reiterate something that Dan had said. Only about 30% of the labs that we get back that are positive don't need to be treated. So then how do we make that determination of what patients we do treat? So then you've got your ACA, your state surveyors coming in. And while Echo Lab and others will say that McGreer's criteria is not evidence-based practice any longer and is not to be used, it is actually something that CMS and the ACA and the state surveyors look at. So if you are starting an antibiotic, they want to see that you meet the criteria for McGeer's criteria. So if we're just looking at urine, okay, over here is the McGeer's criteria. And in order to obtain a urinalysis, you will need one of these four things. So you either need a temperature of greater than 100, a repeated oral temperature, so more than once, so twice or more, of 99 degrees, or a rectal temp, please don't do those, at 99.5, or a single temp of greater than 2 points from baseline. So if there were 97 normally and they're 99, that would indicate you ordering a PCR. So leukocytosis, so you get a white blood cell count back of greater than 14,000, and you're trying to rule out what infection we have. Do we have upper respiratory, lower respiratory? Do we have a urinary tract? Do we have sepsis? Do we have cellulitis? So over 14,000 white blood cells, or greater than 6% bands, or greater than 1,500 bands. So leukocytosis, if you get a white blood cell count and it's high, you can absolutely do a PCR urine and work it up. Acute mental status. So it's got to be acute onset and fluctuating course and inattention and disorganized thinking or altered level of consciousness. So if you've got a patient that's sick and has altered mental status, then absolutely we can do a urinalysis. However, this is one that's really fun. Excuse me, you have a patient that falls, and what does everyone automatically do? They automatically do a urinalysis. Just because you fall doesn't mean that you have a urinary tract infection. And so I want to be very careful and hesitant when we're ordering these PCRs of what the rationale is behind why we're ordering them. And then acute functional decline, and the word is acute. So this is something that you can see off of your MDS, but a 3-point increase in baseline ADL scores. So what if the CNAs are telling you that the patient is able to transfer from the bed to the wheelchair, and they do that every single day, and now all of a sudden they can't get out of bed, that is a transfer issue. If they dress themselves every morning or help get dressed, and now all of a sudden they can't lift their arms, they can't put their arms in, they can't pull up their pants. If you have a continent patient that suddenly turns incontinent or can't get up to use the bathroom, or they go from eating to not eating, zero, like we're not eating, we can't be fed, any of that. So the acute functional decline, nowhere in here does it say falls. So then we have criteria both with a urinary tract infection, with a catheter and without a catheter. So without an indwelling catheter, and I don't know if we can blow this up, we can. You need to have, without a catheter, at least one of the following signs or symptoms. So dysuria or pain, swelling or tenderness of the testes, epididymitis, or prostate. So you have to have at least one of those. And then you've got fever or leukocytosis and one of these. So you have costovertebral angle pain or tenderness, suprapubic pain, gross hematuria, increased incontinence, increased in your urgency, frequency. And if you hit that mark, then you don't have to hit the other. But if you hit the next mark, if there's no fever and there's no leukocytosis, then you're going to need two of the following. So suprapubic pain, gross hematuria, increase in incontinence, urgency, or frequency. So you have to fulfill at least one of these guys right here. And number two, you have to have a microbiology criteria of 50,000 or no more than 2 species. So if you have 3 species, the assumption is it is contaminated. So regardless of whether you're looking at a UA or regardless of whether you're looking at a PCR, you have to have 2 or less. 3 or more indicate that you probably have a contaminated sample. And then this is if you obtain the urine from a catheter, and it says in and out catheter, which means a straight cath, you need to have at least 20,000 of any organism. Well, we don't have that labeled on our new forms. So we have to adjust to how we meet criteria for ACA versus how we meet criteria for this new PCR testing. So the following 2 comments apply to both a UTI or with or without a catheter. So a UTI can be diagnosed without localized symptoms if a blood isolate is the same as the organism from urine. So if you've got a blood culture and it comes back with Proteus, and then you've got a urine that comes back with Proteus, then you don't necessarily need to have any symptoms. We know that there's Proteus going around. Or in the absence of clear alternative source of infection, fever, or rigors with a positive urine culture. So we've got a patient, they've got some sort of an infection or fever, and you do have a positive urine culture in the non-catheterized patient, then you can treat for a UTI. However, evidence suggests that most of these episodes are likely not due to an infection of a urinary source. So urine specimens for culture should be sent out as soon as possible. If they can't be processed within 30 minutes, they should be refrigerated, and we do that. So a UTI with an indwelling catheter is a little bit less rigid. You need to have one of the following sign or symptoms. So you have to have a fever, new onset hypotension with no alternative site. So it's not like you've got a wound infection on your heel, or it's not like you're having a cough. You've got no other signs of infection. You've got either acute change of mental status or acute functional decline. That patient that's fallen 10 times in the last 12 months is not an acute functional decline, and they have no alternate diagnosis or leukocytosis, or new onset suprapubic pain, or costovertebral angle pain, or tenderness. Or if you have purulent discharge from around the catheter, that meets some of the criteria for a UTI with an indwelling catheter. And then your urinary catheter specimen has to be 10 to the 5th. It looks like 10 to the 5th, so 50,000 or more. So if you've got a urinary tract or a urinalysis with 50,000 plus one of the above, then that meets the criteria for a urinary tract infection. So let's just look at this, which is part of what you get back, you also get that fancy little colored sheet that tells you what medications to put them on. But let's look at this, which comes with every PCR that you do. And it's under, when you go to actions, you can actually view the report. Don't just look at that pretty piece of paper. You're going to want to look at this. So this patient has Enterococcus faecalis and it's abnormal and it was detected at high. If you come up to the interpretation, high means that it's greater than 100,000 units. So that means that you've got 100,000 and they meet the criteria if you meet criteria for something else. So that would be a treatable infection. The medium range is horrible. It's horrible. Your chief nursing officer at Aspire and I both agree that having a range of 10 to 100,000 units is not really helpful for us. It doesn't give us the 50,000 to 100,000. And so we have to determine whether we are going to treat these. And so it would say detected, moderate, and then it would say abnormal. You'd see the red note and you'd be like, oh, they need an antibiotic. You'd scroll down, you'd see the pretty paper. It would tell you what antibiotic to put them on. But do they really meet criteria? Well, you don't know because if they're medium, it's between 10 and 100,000. So they have to meet that other qualification for the urinary tract infection. And so you might see 2 abnormals here, and they might just be detected as low. And you see 2, and you're like, oh, this patient has an infection. You get that pretty colored piece of paper that you're using, and it shows that you're going to start them on whatever Augmentin or whatever the antibiotic is. That doesn't mean that patient gets that antibiotic. That means there were 2 bacteria that were in the PCR that were detected. It was a low risk of detection here. And then when you're done looking, do they meet any other criteria? So if you don't have an indwelling catheter, first of all, if you don't have 50,000, and this doesn't tell us if you have 50,000, it tells you 10 to 100. So that doesn't help us any. So if we have a sample, and then we have both 1 and 2. So we have to have one of the following of these guys. So when we're using the diagnosis on our order, if we have a response back here and for whatever reason, somebody did a PCR, we didn't write the order, but they ended up with a PCR and they have a detection of high and it's abnormal, then they meet that criteria for here. But then do they meet the McGreer's criteria for having that? You have to have both 1 and 2 to meet that criteria. So if you start them on antibiotics and they have no symptoms at all, you cannot guarantee that this Enterococcus faecalis is A, active and present, or B, that it's not just stagnant and just sitting there and it's not an active infection. So when you're reading this, and I know we went through it and there's a pretty picture of what medication to put on there, but the more and more we did research on this, the more that this McGeer's criteria does not equate to Echo Labs PCR. So I just wanted to bring that to your attention. I'm sorry that this is such a long video. It was supposed to be a lot shorter than this. If you've got this and you are going to treat it because you do have an abnormal lab, we don't know if it's colonized. It potentially could be. If they have no other symptoms, please think twice about whether you're going to treat them. If you have this Enterococcus faecalis and you have treated them 2 or 3 times, over the last 3 to 4 months, the question then becomes, if they have no other symptoms, is this lying dormant? Is this colonized, or is this an active infection? Do they have these symptoms? A lot of people say older people don't get a fever when they have a urinary tract infection. That's not the only qualifier here. You've got a whole list of qualifiers that you can use. So if you do have fever or leukocytosis plus at least one of the following, then that meets partial criteria, and then this would meet the other criteria. So the answer to the question that I didn't ask, do we have a urinary tract infection, or do we have an abnormal urine result from a PCR, an abnormal urine, and we don't have any other symptoms of a UTI, and are we going to treat it? So they don't have any former labs. This is the newest one we've got. There's nothing in the system. They have no other symptoms. You're going to treat them for the enterococcus. You're going to do a diagnosis of abnormal urine. We know their urine is abnormal, but they don't have the criteria to meet a urinary tract infection based on McGear's criteria, which is required by ACA. So ACA can come behind you and say that that is an inappropriate medication for for this patient because they don't have a urinary tract infection. If you're not familiar with McGear's criteria, we use it in every skilled nursing facility. There's one that talks about for common colds, influenza, pneumonia. What makes the criteria for you to administer medications, antibiotics? And so urinary tract infection is a big one. You know, they walk around with their little laptops or their iPads, and then they click that they had an abnormal urine. But what other symptoms do they have? If they don't have them, it's an abnormal urine. If they meet the criteria, please document that, and then make sure that your diagnosis is a urinary tract infection. I hope that helps. I know that that might be quite complicated, but we really need to make sure that we're not throwing around the word urinary tract infection if they don't meet the criteria for all of that. So they could have an abnormal urine without having a urinary tract infection. It might not be a whole tract infection. It might just be some abnormal urine that we're getting. Why does this matter? Because it affects quality indicators, it affects pay, reimbursement, it affects ACA, and it affects the patients. Why are we medicating if we don't have a legitimate diagnosis? So if you have any questions, please reach out to me. Please reach out in the PCR support group. If you have anything additional to add, I'm definitely willing to re-record this or put more information out for you guys. Thank you so much for your time. Enjoy your afternoon. And hopefully we won't speak for a while and you can enjoy doing your daily thing. Have a great day.